Good morning and welcome to the InTouch Health webinar series. This is Andre Gurowski from InTouch Health, and I will be your host for this webinar. Today we will be featuring Debra Philpot from HCA TriStar, and she will be presenting on the telehealth experience at that location. Debra Philpot is the Neuroscience, Cardiovascular, and Telehealth Administrator of the TriStar Division at Hospital Corporation of America in Nashville, Tennessee. Debra attained her Associate's in Nursing from Indiana State University, her Bachelor's in Nursing from Cumberland University, and her Certificate in Healthcare Management from Indiana University, Purdue University in Indianapolis. Debra has many affiliated memberships and recognitions, including American Association of Critical Care Nurses, AHA-ASA member and Stroke and Cardiovascular Nursing Council member, Rural Health Association of Tennessee member, American Telemedicine Association member, recipient of the Riley McAndrew Excellence Award for Nursing Leadership, and nominee for the Frist Humanitarian Award. We will begin our webinar shortly, but first a few notices. You have all been auto-muted. If not, please make sure you mute yourself. Throughout the webinar, you will be able to enter questions module located on your GoToWebinar panel. Questions will be answered at the conclusion of the presentation, so please feel free to ask your questions at any point throughout the webinar. This webinar will be recorded, and a copy of the recording will be available on our website. A link will be posted at the end of the webinar. This webinar presentation should last approximately 60 minutes, including time for questions and answers. And now, without further ado, here is Debra Philpot.
And that is part of the title, as you see, valuable practices, and you often hear the phrase best practices, and so we certainly don't want to claim that we have all the best, but we certainly have found that in having challenges, we found some that are valuable, and we hope that you will as well. And so I just want to disclose that I'm not a paid speaker. I have no financial disclosure. You will see throughout the presentation some pictures that have the InTouch devices on there, but I have no financial disclosures. Next slide. So really what we're going to try to do is I'm going to give you a little bit of an overview of TriStar and Health, our telehealth network, and a little bit of history and the journey that we've taken. I want to describe some of the challenges that we have faced. They may be unique to us, but I find that many of the challenges are universal. And then we're going to discuss some of those valuable practices to overcome those challenges. And I have a little key at the bottom here, and so when you see a star symbol throughout the presentation, those are the items that I've identified as a valuable practice. And then there's some tools, some processes that are enablers, some toolkits. So what I want to try to do with you is not just kind of talk through it, but give you some example of the tools that we have leveraged through our journey. And then there's a stethoscope symbol, which I really identify those items where it's so important to have a medical staff champion, a physician leader, really engaging your medical staff. And then the other symbol, those around the conference table, is really about a structure, a governance, a meeting, kind of the oversight. So if you'll see those pop up throughout the presentation, you'll get an idea of what those little symbols are associated with. Next slide. So I am a part of Hospital Corporation of America, and I always kind of like to start with this, and we're talking about telemedicine, but it really is about the patients that we all care for. And so in 2011, we started out on our journey, actually in 2010, and we started out doing Telestroke internally only for just a few of the hospitals in our Nashville market. And we started out with only 2 physicians. And next slide. In 2012, we really put structure around this process of rolling out telemedicine. We started, had some success within our own hospitals, and really continued to hear what need there was externally facing, and so we began to extend that service out to others. At the same time, we were able to use the same technology and began to offer behavioral health through licensed mental health assessors in our Atlanta market. And then part of that governance structure, we really became focused about what is it that we want to do. So we set a vision statement and determined what we wanted to do, both at that time and then in the future. And so I think that's really important as you have the opportunity to really sit down and think about what you want to be. And of course it's evolving, but having the right group of people and determining what the needs that you're going to meet. Next slide. A little bit more on the journey. We began to branch out beyond stroke and neurology, and found that because we already had the technology investment, we began to offer some additional services that we identified as needs. Pediatrics, continue to expand behavioral health, critical care pulmonology, neurosurgery, and of course we've added additional ones. We continued to add as we grew, not only in services but in sites, additional providers in our neurology team. And then you see there the expansion that we had. And because of that, and we had a governance structure, but because of the workload involved in credentialing and reporting, we added a dedicated telemedicine coordinator. So I think the lesson learned there right away is that where you start and as you grow your program, you've got to constantly evaluate the resources that are going to be needed. And we also in that same year really rolled out more extensive behavioral health in our Nashville market. Go ahead, next slide. So really where we finished at the end of 2015, we had 33 sites between TriStar and our affiliate partners, and we had over 6,500 telemedicine encounters between those 7 service lines. So pretty extensive growth from 2010, 2011 to 15 over a 5.5-year span, and that just shows you how quickly the needs are rising, and just how you can scale a network and continue to grow it. So next slide. And a little bit more about our network. We do use our own employed physicians for our neurology team. Of course, we use a centralized call center. We've identified a lot of clinical protocols over time. What we started, again, it's been a journey, but we do commit to a 10-minute response time for our code strokes. We offer routine consultations. Again, there's the expansion. Now, our employed physicians, they are a separate call panel. They get paid a separate compensation for that coverage. Next slide. We to talk a little bit about our telemedicine for behavioral health and Telepsych, also called telemental health. So it's got several labels, but we did start out using our licensed mental health assessors. We now use our centralized transfer center, and we also have behavioral health centers where these are the intake where they can provide an assessment, almost an initial assessment, a triage, if you will, for those patients, particularly in emergency rooms that are suffering from behavioral health emergencies. And we have them set up in actually Atlanta, Chattanooga, and their Nashville markets. But we also knew that that was just the first level, and we were just struggling ourselves getting our behavioral health campuses staffed with our own psychiatrist, and we were able to reach out and get an agreement with a third-party vendor, Virtual Medical Staff, and we did a 6-month pilot in our Nashville market using these psychiatrists, again, the same technology that we have for stroke and neurology, and they offered several tiers of care for the patients in this market. We did phase that. We did start out, initially we were doing 24/7 emergency coverage, and now they're just doing after-hours emergency coverage. They are able to be the admitting physician to our inpatient behavioral health campuses. In addition, they are also rounding on those patients on those campuses, particularly at our Skyline Madison campus. So it's not just doing the initial assessment, it's been able to do the intake, process the patient, and then maintain them, because again, we had a gap in our own providers, and so the contracted service through Virtual Medical Staff were able to to meet several levels of care for us. Now, in terms of other things that we've done in behavioral health, we do have affiliation agreements with our external partners who they had Psych units, and they already had their own psychiatrist, but wanted to benefit from that remote access. And so we certainly see a lot of activity from their own psychiatrists, and they essentially sublease the technology from us on a per-hour rate. So it's a different extension of our behavioral health telemedicine services. We also, in the state of Tennessee, have an obligation that if a patient shows up with a behavioral health emergency, that if they're uninsured or if they have our state Medicaid, which is called TennCare, that we're obligated to use our state contracted services. And so Middle Tennessee, you see a list of them there. And what would happen in these rural areas and even urban areas is they would have mental health assessors who were having to go from literally drive from one campus to another, sometimes hours apart. And so we were able to get a USDA grant and provide these offices that are in the rural markets with the software license so that they can remote in and see these patients. And what happened is that they were able to get a quicker evaluation for those patients in emergency rooms that are very rural, and they could use the telemedicine technology and not have to drive from location to location. So that's a little bit about our telehealth network and our services. Next slide. So it's not always easy, and so I listed some of the challenges that we have faced. Some are universal, some may be things that we were just challenged with, and I kind of break them down into a few buckets: legal, regulatory, our clinical challenges, and operational challenges, and we'll go into some detail with each one of these. So next slide. So I always like to keep challenges and problems in perspective. And a good quote I think to remember is that in the middle of every difficulty, and you can put the word challenge or barrier, is really an opportunity. And this is one of the things that I've had to learn in leadership is that these are really truly opportunities, because it allows you to really have the chance to do something better, to do it more efficiently, to deliver more higher quality service, so that whoever's at the end, particularly the patient, but the end user, the physician, everyone that's involved, you've got to be able to do it better. And sometimes we come up against challenges where you'll say it can't be done, it's just too much, it's too complex. And I think you have to have a can-do attitude and keep really working with a team that's open-minded and innovative to get you through some of these difficulties. So with that, I'll switch to the next slide. So again, in the legal regulatory, some of the challenges I'm sure you all have faced is around credentialing. So I've got some stars here for a valuable practice for us. And one of the things that really, in the very beginning, we had our own providers who we were using their practice staff to help us manage the credentialing process. And so what we would find is that one office staff, where they would be on top of it, they would have the applications done, they were really processing things very quickly, and then you would touch back with another office and they haven't even started yet. So we identified that we really needed one person who could corral all these processes, all these applications, all these providers. And that was one of the primary drivers for having a dedicated telemedicine coordinator. So that person really owns and drives the process from beginning to end. Certainly has subject matter expertise, work very closely with the medical staff offices. And we started out with a subcontracting model, kind of paying on the side, and then we rolled it into a full-time FTE. So I would encourage you that it's not easy to get full-time folks assigned with budgetary constraints, but be innovative and kind of phase yourself into it. You certainly need this person to have proxy for those providers that they're going to be credentialing. I think the other valuable practice is really from the very beginning is to try to have consistent processes when possible. Delineation of privileges for telemedicine. You can do one broad one that kind of covers all your service lines, or you can have it built into each one of your subspecialties. Either way you decide, I think when you work in a network, internally and externally, you can offer those recommendations by having these standard bylaw language, standard processes. Certainly when you have 33 sites, it's important to batch those applications. I think that's just the practical process of it. And then it's really managing and tracking is that next step, is making sure you're on track, it's driving the process. And I think the other thing that we learned around this is it is the thing that takes the longest. Even when you're doing credentialing by proxy, it still takes a lot of coordination and understanding where each hospital is in their cycle. Do they meet monthly? Do they meet quarterly? And so these are some of the things that we've identified: single point of contact, having consistent policies and practices, and staying ahead of the tracking process. So next slide. So a few of the other legal regulatory challenges is that for this work, whether you contract a third party or you use your own employed, you have to figure out how do you compensate. And so in the beginning, telemedicine was so new, we had very little calculators and very few people that were experienced. And we took a lot of time just explaining what we were trying to accomplish. And there wasn't really a good tool, and so we tried to retrofit telemedicine into other calculators. But as we've grown and progressed, we have actually found that there are both legal counsel and valuators who have consistent time spent in this space. So again, I think it's back to finding those single points of contact, consistency in the valuation calculators, and having uniform templates in terms of your agreements, where there are more of a plug and play. That has been extremely helpful. But I think the other thing is when you're working with legal counsel, when you're working with your evaluators, is to really have some candid conversation about how long this process is going to take, what your expectation is to turn those items around, just like you would with any other service level agreement. I think this is an area where we have really made big improvements. Again, it's not easy, but throughout the journey we have made some found some valuable processes to the things I've identified here. Next slide. So clinical challenges that you face, whether it's stroke or psychiatry, and really fill in the blank with any other type of service, and that is having a consistent evidence-based care. I think one of the most important things that you need in driving this challenge is you need a medical staff champion, a medical director, a program director, and if you don't have one of those, then a chief medical officer who can really guide and set down, lay out the protocols, whether they're your own internal physicians or if you're contracting with an external partner. I think it's really important, kind of going back to those agreements, to lay out the expectation around response time, around those decisions around evaluating the patient. I think the other challenge that you have in rolling out more than one service line is that beyond the technology, there are things unique to these services that I'm not a subject matter expert in psychiatry, so I need to have someone in that service line, on that team, who really understands the care of the patient, who understands the diagnosis and the disease and the medications. So you really need to have those experts both on the medical staff side and the service line side. And then all that really does is drive your clinical protocols, what your documentation process is, and it should just match up with the evidence that's clearly published for those services. I think another organizational best practice and a tool is that once you identify who those people are going to be on your panel, and you set the expectation around how the care is going to be provided, you need to meet regularly with them and have both clinical and operational discussions. And so in these discussions, it is important to identify barriers for them. So if they're not meeting these clinical guidelines, is there anything in the technical process? Is there anything operationally that you can do? But having regular meetings with them where you're providing feedback but also listening. What would make it easier? How? And it's also a great opportunity for the peer-to-peer discussion where they're having challenges either clinically or operationally, and they can really bounce things off of each other. But I think it's a responsibility of the program directors to get these clinicians together on a regular basis so that you can continue to improve your clinical outcomes. So also I put a barrier is the recruitment and retention of qualified providers. So at the pace that we've grown, we are now, for neurology, I'll stay with that example for a minute, I saw on the screen 6 providers, but we are adding 3 more and we'll be up to 9. It's really challenging to find providers who typically they will have a day job. And so you're asking them to take on something more. And so really what's in it for them? And trying to make sure that you have the right providers for the right reasons is extremely important to maintain the integrity of your program. And so no matter how desperate you feel about adding someone to that panel, make sure that they meet the clinical requirements. Your program may require board certification, but that's where your kind of that evidence-based team can really set the expectation for it. Once you get them in your call panel, the support that they need, one of the things that we have done is add a full-time IT specialist, and it's a senior project manager. And literally, they can reach out to this person almost 24/7 and get the support they need if they're not connecting to a device or to an electronic medical record that they need, or through image sharing. So it's getting them support. It's finding that they all have the same consistent setup technically, using similar devices, imaging the equipment the same, all of those things that really can help support them. I think it's important to, as you're analyzing their volume of work, that you also analyze the compensation, because these folks can burn out very quickly. Even if they're not having a lot of activations, the burden of calls is extremely heavy. They are tied down to it. So find ways to evaluate their compensation, offer incentives through that compensation model. And I'll give you an example of that is when you can have a flat rate, and then once you exceed a certain number of consults within that time period, then you can have an incentive for each consultation. Now that takes tracking, but I think it gives them some sense that I'm getting compensated, I'm getting rewarded for kind of above and beyond reasonable volume of work. I think the other thing is just managing rotations and call schedules and time off, working in advance, setting expectations around holidays and weekends, and what kind of expectations. So a lot to be said on that, but I think it's a real challenge. It's not an easy one, but again, just working very closely with providers and trying to recruit and retain really valuable, highly skilled team members who are committed to the mission of your service. Once you get these folks, I think the other challenge is just training and competency. So I want to share some things, some checklists, some certificates. Sometimes the training, you're not sitting down with them, so how do you do that? And I've already mentioned the dedicated technical support person that you can provide. It's been a very valuable practice for us. And then in terms of the competency, one of the valuable practices I'd like to share, part of that regular meeting that I mentioned with providers is that we blind the consultations, and we do an internal audit and have an internal peer review process, again, to maintain the competency. Is there anyone that's working outside of that clinical guideline? Was there any judgment or recommendation made that wasn't consistent? And so one of our competency validations is this internal audit, and it's been extremely helpful for each individual to identify opportunities, but to identify global trends and practice patterns. So next slide. So this is one of the tools. I mentioned processes. I think it's really important whether you're rolling out any layer of service, that service line expert, that subject matter expert, really needs to lay out in a flow chart, a diagram, an algorithm, how is this going to work? How is it going to be operationalized? And that needs to happen, again, with somebody who has expertise in it, but also partnering with the physician and the frontline staff to make sure everybody's on the same page about how do you activate it? What are the indications? What's the response time? So I just wanted to kind of give an example, and we certainly have a workflow for every service that we roll out in telehealth. Next slide. And another valuable tool that we've had in terms of the clinical challenges is around standardization of our documentation. And we had, in the beginning, just to tell you a little bit of the journey in the stroke world, we had developed our own clinical note, and it was getting fax mail to the hospitals. And it was actually a very good note, but then we still had some providers who were dictating, and we really had a hard time analyzing our effectiveness and our documentation consistency because it truly was all over the place. And we went to a unified note through the clinical applications as a part of the software. And that physician team that we meet regularly, they actually were extremely involved in establishing the layout, the flow, the content. And so because they were invested in it, I think we've had great success at the adoption of a consistent note. And again, it makes it extremely helpful for us to identify those any variation in clinical practice because we have visibility and access to every single one of these consult notes. So next slide. We have done a very similar thing, and this is actual screenshots of the clinical notes, but instead of for stroke, it's for our behavioral health. And these can be kind of a canned approach, or they can be customized by service line. And this is just a screenshot of a helpful tool that we've had to, again, have consistency in the documentation. And it's really laid out just like any other H&P would be. Go ahead, next slide. In terms of training and competency as a challenge, on the initial side, what we have done for every single service line is develop a specific physician checklist. So when we are doing their training, it is very clear on the things that they're going to be trained on. There's a return demonstration, and it is validated. So this is an example of a physician competency checklist, a great tool that we've used for our behavioral health psychiatrists. Next slide. And then the final valuable process that I wanted to share is that when you do have multiple physicians that you're bringing in, sometimes they're right next door, but sometimes they can be 2 or 3 states away, is to identify the resources and set up WebEx training where you can demo and then you can actually observe these physicians working through the software. And we've also created online resources and quick reference material so that as you bring these folks on, they have the right resources. Next slide. Ooh, that one back. There we go. So a few of the operational challenges that we have had, again, in telemedicine, because it really has rolled out so quickly, I think it's been challenging for some to even know who really owns it. Is it owned at the hospital level? Is it owned at a network level? And who's the right person to own it? So we're going to talk a little bit about this governance. Through our journey, I started out at the hospital level and then evolved into being at the division level. But even then, it was really identifying and letting everyone know in the market and the division about when you have an idea for telemedicine, there's a way to funnel that. And so typically what we would find is that there would be a need someone would say, hey, can telemedicine meet this need, then they might call IT, or they might call really anybody. It's whoever they think of locally. And so these requests were kind of coming up through all different channels. And then there was this time frame where everyone was kind of trying to figure it out. And so we called a timeout and really structured, as I said, from the very beginning. But I think it's important to have structure around the team, who's going to own it, having the service line involvement, medical staff. The other piece is in terms of process improvement, you can't improve what you don't measure, either from the clinical side, the operational side, or the financial side. So making sure that on your governance team that you include your controllers who can pull billing information for you, or the business analyst if you're looking at a return on your investment, making sure that you have those right team members in. Project management, we're going to spend some time in more detail on this, but just when you start something, carrying it through to the end. It is so challenging with all the other priorities to take an idea, find an owner, and then make sure it gets done. So from individual projects to who has that inventory of everything that you're working on, and then who's managing all these sites and all these users. Those are all challenges. But what we have tried to do is, again, through that governance structure, identify who is doing what, almost like a team charter, and set some expectations on the front end. And then I mentioned measurement. You cannot really do anything in this day and age without understanding the reporting and having optics about what you're doing. Utilization, again, by site, by provider, by what type of service, trending it by time of day. And really, over 5 years, we even understand what big data is in our subset of the world, because we've had to tap into that data, because when we were growing, when do we need a new provider? Can we add a new site? And we answer those questions by then turning back to our data and analyzing the reports that we do have. Productivity and capacity analysis, I mentioned that. So what's one physician call burden versus another? Even though you may have a greater call burden, how many patients are you actually seeing per hour? So then when you hear it's super busy, I'm overloaded, well, make sure that you have a way to objectify that comment by analyzing the productivity and the workload of each provider. So again, I think the valuable practice here is know what you want to measure, have a process to measure it regularly, so and then develop actions off of it. You really can't do it all at one time, and have the right people pulling the right reports for the right reasons. So no one wants to just look at data if we're not going to do anything with it. I think a valuable practice is really having this governance structure so we know what we're going to measure and who really owns it. So some of the other challenges: clinical processes, outcomes, creating scorecards, and I'll show you some valuable tools that we've created. And then patient experience, how do we measure that? So next slide. So this is a little bit on the valuable organizational structure. Again, have a team. This is just an example here that has legal, that has your outreach team. Again, I mentioned controllers and billers and coders. There are all these people who can help you, and if you're expanding a network and it is challenging, look within the organization, either locally or at the division or market level, to pull in all these appropriate resources. But this team will then have an executive level who can approve or decline new services, new sites, and really can help evaluate the whole program as a whole, and then down at the granular level. But this team will then making sure that you're meeting regulatory compliance, that you're truly analyzing the value of the program at many different levels. Next slide. This is an example of a valuable tool. So if you're rolling out, this form is really a patient perception of care survey. It's very short, so this is an example of telepulmonology or telecritical care, but you can add that to psychiatry or stroke or pediatrics. And it's you don't have to do it forever, but I think it's a valuable practice that as you start a service, you understand how that is impacting in a positive or negative way to your overall patient experience. So I wanted to share that valuable tool. Next slide. Another part of operations challenges is managing all the technology. So there's the technology that faces the patient, and when you're rolling out and expanding your program, when you need to have a process to analyze, well, which technology do we need? Which one, what kind of clinical uses are we going to have? Are we going to need to add in ancillaries? I may start out in a location that I only need behavioral health, but what's the possibility of expanding it to other services? So having the right technical folks and the right service line folks and the right strategic people looking at your overall market strategy, your business plan, so that you don't back yourself into a corner, but at the same time you're also being responsible with your resources. And then once you decide which each expansion site, it's then managing the model. If you lease them, you've got to keep track of those payments and when they're going to expire. And then also there's the physician-facing side, the provider-facing side, what technology you're going to give to them or ask them to bring to the table. How are you going to support them in that? And that's all a part of the technology assessment. Again, there's not a single solution, but knowing that you have options and knowing where and when you want to scale is important. Again, I think that rolls back to having that governance structure so that you don't have one service line making a decision in isolation and then without thinking of the bigger picture. So this is one of the valuable processes that I think is important to have these conversations frequently about the right types of technology on both sides, the patient side and the provider side, and that we're keeping up with the demands, but not overreaching when we don't have to. Next slide. So in terms of process and project management, something that's kind of near and dear to my heart, and one of the things I wanted to share with you all as valuable is an implementation kind of a toolkit where if you're rolling out stroke or neuro or psych or any other service, we have an agnostic toolkit that kind of takes you through a regular process so it's consistent. So we have an implementation planning meeting, and this goes for internal and external customers. So an example, if we have an internal customer who wants their physiatrist to in their inpatient rehab to use it, we use a very similar kind of process, maybe abbreviated, but we have an implementation meeting and we start walking through these steps of project management. And I think the one here, first of all, and the next slide, is identifying who are the key stakeholders. So again, whether it's internal or external, who needs to be involved and identifying those folks. Next slide is once I know who needs to be involved, again, back to that technology assessment, is what exactly do you need? What services is it going to have now and in the future? How do you set up those services? And so part of that implementation playbook is this IT assessment installation, and having that single point of contact. It's extremely valuable to us to have the one person who, no matter where we go with what service, they are very familiar with it. They, again, drive the process from a technical perspective. Next slide is valuable tools that we use in that process. So internally, externally, we ask you to maybe evaluate what is the need, who's the owner, what's the IP addresses, and these are just some of the tools that we have used to help us drive that assessment. Next slide. Credentialing privilege, won't spend a lot of time here, but I think the valuable process here is that single point of contact and establishing the timelines that are reasonable to execute on expanding your services. Next slide. I think this is a critical, important step when you're rolling out a process and we are expanding your services internally or externally. It is about that physician engagement. So it's important that you have the right people at the table, and that might include physicians that you might not think of, hospitalists, ED physicians, the subspecialists. Really, it's better to be more exclusive than inclusive when you get the physicians in the room together. So that, again, this key physician meeting is, if we don't get this done during an implementation of a new service or a new site, then we don't move on. We absolutely stop here until we're able to get all the physicians talking together and agree on protocols and access and all of the things that make a successful implementation. Next slide. Another step is that clinical staff meeting. Again, depending on the service, having those conversations and making sure that you've got buy-in and support for that implementation. So it's another step in the playbook. Next slide. And then this is the result, the end result of having those clinical conversations, is that you develop an evidence-based protocol. It's customized for that service or that site, but it is a collaborative effort in rolling out, again, a well-defined process. Everybody's on the same page. Next slide. Training, just one best practice I want to share with you here is that we have found that if we require and actually have attestation that is a part of a rollout at a new site or a new service, that we require 80% of the staff to be trained prior to going live. And then we find also ways to continue that education through adding it to an orientation process. But before go live, 80% is the number that we have found. If you don't hit that number, you're going to have a rocky implementation, and it's a lot harder to pick it back up after a rough start than it is to start it right, and training is essential to that. Next slide. And I don't think this is anything new to anyone, but before you go live is the mock codes and the practice runs, the dry runs. And the next slide is the tool that we use to evaluate. When we do that practice run, we have tools. This one is per stroke, but we would do it for any service that we roll out. Again, if we don't do a practice, if we don't have a positive evaluation, we keep doing it until we get it right. So this is a valuable tool for us. Next slide. And then before we go live in a new rollout or expanding a service, we really call a timeout on that weekly meeting, and then we use, and you can actually go to the next slide, we actually go through a go live checklist, and this would be at the administrator level. So if it's the CEO or the CNO that owns that process or that project, we will go through this together, and I myself and that business owner on that side will also sign off. But we'll make sure we get the training, everything's working right, we had a positive practice run, and then also some of the communication that we've covered as well. So a very valuable tool to us that really has helped us kind of stick to the plan, making sure everything's done consistently. Next slide. The other valuable practice is just after 30 days, go back in, sit down with that very same planning team, and how's it going? So then you can go ahead and go to the next slide. And then also identifying what regular intervals you're going to go back and evaluate how's it going, what's working, what's not working, and that's communication on both ways. That's why analytics are so important to drive that improvement, to have that conversation. If you're not gathering the right data, it's very difficult to go out and have process improvement meetings with internal or external partners. Next slide. And this is an example of a valuable tool. This is a report card, if you will, that you can create no matter what service you're offering. And once you have identified what you're going to measure, again, back to a valuable practice, identify it on the front end. Then when you're going out, you're you have the optics and the metrics that you want to look at, and that will help you drive your improvement process. Next slide. So we're going to summarize things that we've talked about. When you're looking at expanding your network and some of the challenges, it's knowing how much you're doing, where you're doing it, collecting that data, analyzing that data, both financially and clinically. Do you have the right partners? Are in the right locations? Does it still make sense? It might have made sense 3 years ago. Always analyzing the right location. Making sure that you're not trumping external needs for your own internal. Sort of want to make sure that you take care of your own needs as well. And then right locations in terms of those who are grant applicable and who's going to oversee that process for grant application. I think right staffing. Do you have the right physicians? Do you have the right number of physicians? Do you have the right pay, the right compensation? And how's that affecting your outcomes, response times, and patient perception? And right staffing also for your own team. As you grow and expand, constantly ask the question, do we have the right people on the team? When do we need to bring in additional resources? And then right services. We often get requests for telemedicine services, and sometimes telemedicine is just not going to fix that need. And so we have created, some forums and some discussions to make sure that we are actually getting the real need versus a perceived one. Service line expertise, workflow, and many of the things that we've talked about. And then the technology as well, always analyzing, reanalyzing the technology that you're using, using a consistent platform, making sure that you're meeting the compliance and it's cost effective. And finally, so just a few final comments on what I consider is valuable practices when you're trying to expand Telestroke and Telepsych. Start out internal, kind of test that on yourself to make sure that it actually is meeting the need that you have. And if not, why? Go back and tweak it. Start in one facility internally and then expand it to other facilities. Validate that you have effectiveness. Measure what you're doing. Then continue to expand it. And then eventually you can go out and you can offer that. Once you've kind of perfected the services, then begin to offer it. A lot of the challenges is that if you have a network and you're going out meeting with partners, they'll often say, we really need, and you fill in the blank, pediatrics. And you're thinking, we really do too. So, but it's hard to go out and really offer something to someone until you've really vetted it out yourself. So I would say, as you expand, you learn something new every day. Build on those lessons learned. Don't lose sight of what's worked for you. So if you have a good process, whatever that is, keep using it until proven otherwise. Stick with it. Know what success is and measure it. Make sure that whoever you're working with on your team is being developed and grown and that they're being educated and rewarded. Know that it takes a team, so involve all your stakeholders. I think it's really important as you expand to know what's happening in your state. Are you a parity state? Do you require informed consent? So as you expand, you need to be staying abreast of state and national policy changes. And I always start and end with, as you expand with all the resources and all the challenges, I think that if you can keep the patient first, above all else, you will be able to improve the care of our patients if you take that proven roadmap. With that, I will end and take any questions.
Debra, thank you so much for that. And even though we're at the top of the hour, I'm going to do a 5-minute Q&A for those that want to stay on because we do have quite a few questions from the group. So one of the questions was around charging hospitals. So Debra, do you charge hospitals not in your network a service fee for monthly or yearly? And how do you think about charging those fees if you do?
So the first thing that we do is we have, there's OIG guidance, Office of Inspector General guidance, and we have standardized an assessment form. again, kind of back to that legal regulatory. And then we go through that questionnaire, we answer it, we provide it to our legal counsel with their review. They say this site either meets or does not meet the guidance and the boundary for the OIG exception. If they meet it, then we kind of are able to offer both the technical service and the physician coverage at free or less than fair market value. If they don't meet those guidelines, then we go do and offer a fair market value charge for that same service. So that's really the algorithm that we have, is you complete that assessment form and you either make the grade or you don't. And we kind of have an idea of those sites that are probably going to be eligible for it and those that are not.
Great. So a little bit follow-on around that is regarding your neurosurgery line. Is that just for follow-up surgery, or are you? How else are you thinking about the neurosurgery?
So the neurosurgery is fairly similar to a neurology, but it is not a 24/7 call panel. So we have neurosurgeons that cover more than one location, and they may get a call from the ER at one of our sites and say, hey, we have this patient with an intracerebral hemorrhage. And neurosurgery is, they like to see the patient, and in addition to seeing the scan, so we've got them set up with the ability to see those remote images, but they can also connect to the technology that's right there at the bedside, and they can do that evaluation and also then make a recommendation, hey, this patient needs to go to a higher level of care, or no, put this patient, stay at the primary stroke center and, admit them with these admitting orders and these recommendations, and I'll be and see them in the morning. So they're using it as a triage tool. It is not a 24/7 call panel, but it does extend the reach and the quality of the decision making, and obviously the time to see a neurosurgeon. It reduces that greatly.
So, Deborah, another question is around the subleasing of your robots. Is it of the services of the devices, right? Is it included in a service fee, or how do you negotiate the subleasing?
So all of our technology, we have a leasing model. It's a 35-month lease, and so if what we do is we know that a consultation, by the time you log on, beam in, connect with the technology, and then complete the note, the whole process takes about an hour. And so what we do is we know how much we pay per month, and then we just do the math and say, well, that hour of using the robot there, because that's outside of the fair market or the OIG guidance, we couldn't offer the use of that technology for free. So we have to charge you for it, and then we just pass off our cost for that hour of using the technology. It's not necessarily it's not a money-making endeavor, but it keeps us in regulatory compliance. And so what we do on the agreement is we actually add an addendum to the agreement, and we put that dollar amount. Of course, then we have to track it, and then we have to invoice that facility for those that sublease, and then track to make sure we get paid.
Great. So we're going to go ahead and end the webinar now. I want to say thank you so much to Debra and to HCA TriStar for today's presentation. If you have to the audience, if you have additional questions or looking for more information, you can contact InTouch Health at questions@intouchhealth.com. You see that on the screen. Or you can contact Debra directly. I put her email on the screen as well for those that are interested. And then also, as I mentioned, the slides will be made available at intouchhealth.com under Telehealth Resources, Webinars. You can visit our website, www.intouchhealth.com, to find more information. Debra, again, thank you, and we appreciate your time.
You're welcome. My pleasure.
All right. Bye-bye.